Hey guys, welcome to ST3 Hacks. Hope you're well. We are at the start of January, so hopefully you guys are well into your revision. A couple of recommendations: you want to keep on top of the fun orthopedic lectures. They're a pretty good resource. Hopefully you formed your groups, 2 to 3 people, where you can really grow yourselves over the next 2 to 3 months and do the best you can in your interviews. So in this episode today, we're going to be doing proximal humerus fractures. Always we'll start with the background knowledge you should already have in your head before you even approach this interview. And then we'll move on to how you structure your answer in the station itself. So starting with the pathoanatomy, this is important because the deformity you see on the x-ray has certain patterns, and we want to figure out what fragments move because of which muscle pull. So the greater tuberosity tends to displace posterior superiorly and externally rotate, driven by the infraspinatus and teres minor. The lesser tuberosity internally rotates and is medially displaced by the action of the subscapularis. The humeral shaft moves anterior medially, displaced by the action of the pectoralis major. So if you understand these concepts, you can make sense of the radiograph more easily. Moving on, something called the Hertel's criteria predicts humeral head ischemia. The criteria includes displacement of more than 10 millimeters, angulation more than 45 degrees, a disrupted medial hinge, and less than 8 millimeters calcar length attached to the articular segment. One easy to misunderstand concept is about pseudosubluxation, which can be due to hemarthrosis or rotator cuff insufficiency. Moving on, there is the NEAR classification, which is a widely used system for categorizing proximal humerus fractures based on the number of displaced segments. And these are divided into the head, greater tuberosity, lesser tuberosity, and shaft, and the degree of displacement or angulation, mostly displacement by more than 10 millimeters and angulation more than 45 degrees. On the radiograph, you should comment on the surgical neck, how many parts the fracture has had, is it displaced or undisplaced, does it look dislocated? And you should always ask for orthogonal views if they give you only one view. When you structure to answer the question, you should open with safety and context. Something like, this is commonly a low energy injury in a frail osteoporotic patient, so I'd approach this as a silver trauma and assess for other injuries and medical precipitants. So you want to tell them specifically you're concerned about neurovascular damage, axillary nerve is the most commonly injured, you're worried about fracture dislocation or any other injuries to the scapula which may result in a floating shoulder if there's high energy. There is a guideline that you can mention here from NICE that looks really good. That is the NICE guideline 38 for non-complex fractures, in which you can consider surgical intervention for proximal humeral fractures if there is vascular injury, it's an open fracture, skin tenting, if there's a fracture dislocation, or there is humeral head splitting. Then you take a detailed history covering mechanism of injury, hand dominance, baseline function, past medical history, and specifically social history with diabetes, smoking, and their functional status. This is where the interviews are checking whether you're thinking ahead to rehabilitation and operative management. In examination, you don't need to get fancy. You inspect for deformity, swelling, skin tenting, the extensive ecchymosis, which often tracks across the chest and the arm. You should palpate the clavicle and scapular spine because these associated injuries can often get mixed. And then you should document neurovascular status, particularly the axillary nerve sensation over the regimental badge area. Okay, moving on to investigations, you should keep it purposeful. So you want the trauma bloods along with a bone profile and vitamin D if appropriate, radiographs with proper orthogonal views, and a CT if the fracture pattern suggests a head split or surgical planning would be unclear. Management starts simply and safely. You should immobilize the patient in a collar and cuff, provide adequate analgesia, and escalate early. Saying I discussed this with the on-call consultant and involve an upper limb specialist early if needed when deciding for operative management. When you talk about definitive management, you frame it as a spectrum. Options range from non-operative care through closed reduction and pinning, and open reduction internal fixation, intermedullary nailing, to arthroplasty. You don't advocate a single approach as a prospective ST3. This shows judgment and awareness of the options that you have with this patient. This is where evidence comes in. For an enlocated shoulder without red flags, non-operative management is often appropriate, supported by evidence such as the Prophet trial, showing no functional difference at 12 months for many 1 to 4 part fractures. Being a stronger candidate, you should also be aware about the Prophet 2 trial, which was done to mitigate factors in the original study, such as including a range of ages. The first trial actually grouped all operative types into one, combining 2-part fractures up to 4-part fractures all in one group, where arguably 4-part fractures are much more complex and severe. So what other factors should be affecting your decision-making? If they ask you that, you must divide it into 2 segments. So patient factors, such as age, hand dominance, functional demand through occupation and hobbies, past medical history, such as diabetes, any other problem that can influence anesthetic considerations, and importantly, smoking status, and the likelihood of the patient to comply with post-operative rehab. Then there is injury factors, degree of comminution, fracture dislocation, open or impending open fracture, neurovascular compromise, a humeral head split, any associated injuries in a polytrauma patient. So proximal humerus fractures aren't about showing off classifications or trials, but they're about understanding safety, structure, and then surgical decision-making. That's it for this episode of ST3 Hacks, and I'll see you in the next one.